Welcome all. So we continue with our carcinoma of cervix. Last time we have discussed about the carcinoma in situ, and now we will discuss about further about the treatment of carcinoma of cervix and what are the different treatment modalities. Okay. So what are the frequently asked questions on this particular topic? You may be asked about discuss the etiology and pathogenesis of carcinoma of cervix, describe HPV vaccination and cervical cancer screening, describe FIGO staging of the carcinoma of cervix, discuss investigations in cases of carcinoma of cervix, and various short notes which can be asked like transformation zone, HPV vaccination, visual inspection with acetic acid, pap smear, HPV DNA testing, CIN, risk factors, then FIGO staging, is spread of carcinoma of cervix. These are the various short notes which can be asked. Okay, couple of things which we have seen last time from this. So we continue further. So what exactly this carcinoma of cervix is? Actually, whenever you are asked or you are talking about carcinoma of cervix, certain things which you should emphasize that this is a preventable malignancy. Okay, so carcinoma of cervix is a malignant neoplasm arising from the cervix, most commonly from the transformation zone following persistent infection with a high risk HPV. Okay, so it is a malignant neoplasm or preventable malignant neoplasm arising from the cervix, most commonly from the transformation zone following persistent infection with high risk HPV. Okay, so everything is very important. The persistence of the HPV infection is also important, and high risk HPV, that is also important, because there are certain high risk HPV types and there are certain low risk types. Okay, so what is the global burden? This is the fourth, as per the WHO, this is the fourth most common cancer among women worldwide. One of the leading causes of cancer related mortality in women. Burden is highest in the low and middle income countries and largely preventable through vaccination and screening. Okay, so there are certain important facts about the carcinoma of cervix. The high risk HPV is necessary for the causation of the cervical cancer. Okay, so this high risk HPV, that is 16, 18 most common. Okay, nearly 99% of the cervical cancers are associated with the persistent high risk HPV infection. Most cases occur between 33 to 55 years. Okay, so from examination point of view, always begin long answer with carcinoma of cervix is a preventable malignancy caused by persistent infection with the oncogenic HPV. Okay, carcinoma of cervix is a preventable malignancy caused by persistent infection with the oncogenic HPV. That should be your beginning sentence. Then, as far as Indian scenario is concerned, this is the second most common gynecological malignancy in many regions. Higher incidence is due to one, there is a poor screening coverage in the, especially in the developing countries, then early marriages, high parity, low socioeconomic status, and limited HPV vaccination. So these are the factors which are contributing to the high prevalence of this particular malignancy. Okay, so whenever you are describing any surgical questions or writing question, you should always write the relevant anatomy, what we call it as a surgical anatomy. Okay, so what is the surgical anatomy of the cervix? Length of the cervix is around 2.5 to 3 centimeter. It has got two parts, the supravaginal part and the vaginal part. Supravaginal part is above the vagina. It is related to the bladder anteriorly and related to the rectum posteriorly. While the vaginal part will project into the vagina, it is covered by the stratified squamous epithelium. Okay, so the surgical anatomy you should write when it is a long question. The endocervix is lined by the columnar epithelium and it contains the endocervical glands. Then the transformation zone, most of this we have seen last time. It is actually the area between the original squamocolumnar junction and the new squamocolumnar junction. Okay, and which one is outside and which one is inside? The original columnar junction is outside and or laterally, and medially will be the new columnar junction, because the original columnar junction is not static. Okay, under the influence of estrogen in the young reproductive age group, it will come outside, and that is why the columnar epithelium will be exposed to the vaginal acidity. Then there will be metaplastic changes, and that columnar epithelium will be replaced by the squamous epithelium, and that is why new columnar junction will be formed medial to the previous one. Okay, so the here this original squamocolumnar junction will be outside, and medial to it will be the new squamocolumnar junction. So this is the site of origin of almost all cervical cancer. Okay, what is the importance of the transformation zone? It has got a maximum metaplastic activity. HPV infection happens here, CIN develops here, and most biopsies are taken from this particular area because that is the site. So we will always take the biopsy from this particular site. What is the blood supply of the cervix? The uterine artery through the descending cervical branch and the vaginal artery. Venous drainage is through the uterovaginal plexus. Lymphatic drainage, primary nodes are primarily it will go to the parametrial, then obturator, internal iliac, and external iliac. Okay, so these are the primary nodes. Parametrial, obturator, internal iliac, external iliac. Secondary nodes will be the common iliac, then presacral and the para-aortic. Okay, so these are secondary nodes. So lymphatic drainage is also commonly asked either in the viva, or there may be some question in paper 1 also. You may be asked about the lymphatic drainage of the cervix. That is the basic science or the anatomy which is related to the obstetrics and gynecology. Okay, so what is the etiology and risk factors related to the carcinoma of cervix? The necessary cause for the development of the carcinoma cervix is the persistent infection with the high risk HPV. Okay, you have to say in this particular fashion, persistent infection with the high risk HPV. Then what are the high risk HPV types? That is 16, 18, 31, 33, 45, and 52. Okay, so 16 and 18 are the most common one. Okay, so these are the high risk types: 16, 18, 31, 33, 45, 52, and 58. And there are other associated risk factors apart from HPV. These factors are the sexual factors, reproductive factors, viral factors, host factors, and other associated factors. So sexual factors like early age at first intercourse, then multiple sexual partners, partner with multiple sexual partners. Okay, then reproductive factors, high parity, early first pregnancy, viral factors, persistent HPV infection that we have already seen, then host factors like immunosuppression, HIV, smoking, malnutrition, etc. And other factors like low socioeconomic status, poor genital hygiene, long-term oral contraceptive use is a very small risk. Okay, Aetiopathogenesis, this also we discussed briefly in the last session, but we will revise it again. So there is a persistent HPV infection. Most of the time HPV infection is a transient infection because 90% of the cases it gets cleared. Only those patients where there will be persistent high risk HPV infection, that will lead to the CIN, and from CIN it will be a spectrum from CIN1 to CIN2 to CIN3, then CIS, and then invasive carcinoma. So before invasive, this is a micro-invasive carcinoma first. Okay. So, and then there is a invasive carcinoma. And molecular basis also we have noted there are two villains from the HPV. One is a E6 protein and another is a E7 protein. Okay. So this HPV E6 protein will destroy the P53. Okay. That will lead to the loss of apoptosis, leading to the DNA damage which gets accumulated, and that will lead to the cancer. Okay, so there is a destruction of the P53 by the HPV E6 protein. What does HPV E7 protein do? It will inactivate the RB protein, retinoblastoma protein, and that will lead to the uncontrolled cell division, leading to the malignancy. Okay, so this also last time we have seen CIN1, CIN2, CIN3, CIN1 where the dysplastic changes are restricted to the lower 1/3, CIN2 where the changes are up to 2/3, and CIN3 there is a more than 2/3, almost full thickness. Okay, and the risk is less with the CIN1 while the risk is high as it goes to the CIN3. Invasive cancer where there is a breach in the basement membrane, and the cancer cells will start spreading. So this is the frank malignancy. Okay, now coming to the prevention. Okay, so here there can be a short note. Okay, so primary prevention is by HPV vaccination. So current WHO recommendation, the target group is girls between 9 to 14 years is the preferred target age group. and vaccinate both before the sexual debut. Okay, so they should be vaccinated before the sexual debut. Age group targeted is 9 to 14 years. Okay, but the catch-up vaccination can be given up to 26 years. So young women, according to national recommendations, often up to 26 years can be given this vaccine. Some guidelines extend the shared decision making beyond this. So after 26 weeks, it is 26 years, it is a shared decision making. Okay. So what are the different vaccines which are available? We have the bivalent vaccine, and the HPV type covered is a 16 and 18. Then we have a quadrivalent vaccine, that HPV type covered is a 6, 11, 16 and 18. And then we have nonavalent vaccine, in which low risk and high risk both are covered, in which those which cause the wards, they are also covered. So 6, 11, 16, 18, 31, 33, 45, 52 and 58. Okay. So these are the basically high risk. The one which cause the what, they are also covered, and the one which cause the this high risk HPV leading to the carcinoma cervix, they are also covered. Okay. So what is the dosing schedule? For girls and boys between 9 and 14 years, only 2 doses. Okay. The interval between the 2 doses is minimum 5 months. Okay. So first dose is given at 0. Then second dose is after 5 months you have to give. uh, Between 5 and 13 months is the second dose. So 0.5 ml is given intramuscularly. 2 doses are required. This is the primary vaccination. If second dose is given before 5 months after the first dose, then third dose is required. Okay. So as per the third dose schedule, the second dose, if it is given below before 5 months after the first, then you give third dose. Okay. So extra dose is needed for adequate immunity if the second dose is received before 5 months. Then after the age of 15, or at the age of 15, you need to give 3 doses. That is 0, 1 and 6 months. 0.5 ml given intramuscularly. Okay. And for immunocompromised individual, always 3 doses are given: 0, 1 and 6 months. That is recommended irrespective of the age. Okay. So if you have got a immunocompromise between 9 to 14, then also they will receive 3 doses, because for immunocompromise, it is always 3 doses irrespective of the age group. Okay. This you have to keep in mind. Okay. Now coming to the quick revision for this. So dose is 0.5 ml given intramuscularly, routinely 2 doses. Minimum age for vaccination is 9 years. So 2 dose schedule is between 9 to 14 years. The first it is given 0 and 5 to 13 months second dose. 3 dose schedule, 15 years or more. For immunocompromised patients also of all ages, you will give 3 doses, that is 0, 1 and 6 months. If second dose is administered before 5 months, then you will give the third dose also. Okay. So what are the contraindications for vaccination? Severe allergy to the previous dose. Pregnancy, you will defer until after the delivery. Then important facts: vaccine will prevent the infection. Vaccine does not treat the existing CIN, and screening must continue after vaccination. So this also last time we have discussed, even if you give vaccine, that is not a replacement for the screening. Okay. So is it a replacement for the screening vaccination? No. Though it is a primary prevention, the screening should continue. Okay. Now coming to the secondary prevention. These terminologies, primary prevention, secondary prevention, what comes under this, that you should be able to understand and write it properly. Then it is a secondary prevention, that is cervical cancer screening. Okay. Actually, cervical cancer screening for MRCOG, what we discuss, is little different because these screening guidelines differ from country to country. Okay. So for MRCOG, we will follow different schedule. This is for your examinations, you can follow this. Less than 21 years, no screening is recommended. Between 21 to 29 years, cytology by pap smear every 3 years. Okay, that is more than sufficient. And between 30 to 65 years, primary HPV testing, if it is available, that is best, or co-testing, that is papinicola smear along with primary HPV testing, or cytology, that can be that you have to do between 30 to 65 years. And after 65 years, if your primary screening is negative, then you will stop if adequately screened and the patient is found to be low risk. Okay. So screening strategies will vary from country to country. For your examination, we can follow this particular what I have discussed. Okay. Then screening methods. uh, Screening routinely, what we follow: Papillary smear that is widely available, but limitation is that it has got a moderate sensitivity. Another is the HPV DNA. It has got the highest sensitivity, but the cost is the limiting factor. Okay, so you should present your information in this particular manner so that the examiner catches the information that you know everything. Okay, so HPV DNA has got the highest sensitivity, but the cost is the limiting factor. Then VIA, it is cheap, but again low specificity. Then visual inspection with legal iodine, it is useful in low resource settings. However, it is operator dependent. Okay, so these are the methods which are available. That is papillary smear, moderate sensitivity, HPV DNA, highly sensitive, but cost is the factor. VIA is available and VILI. Okay, these are the techniques which are available for the screening. Then what is the clinical presentation? This can be a routine viva question. How does the CS cervix present? So postmenopausal, postcoital bleeding, then intermenstrual bleeding, postmenopausal bleeding, excessive white discharge, foul smelling discharge, pelvic pain, backache, weight loss, hematuria, and rectal bleeding will be in there in the advanced cases. Okay, so the postcoital bleeding, intermenstrual bleeding, postmenopausal bleeding, excessive white discharge, foul smelling discharge, pelvic pain, backache, these are the symptoms. Signs, there will be pallor, weight loss, and locally what you will see, there is a friable cervical growth, ulcerative lesion, barrel-shaped cervix, contact bleeding will be there, parametrial involvement you may find, and on per rectal examination and pelvic wall fixation in advanced cases. Okay, so locally there may be friable cervical growth, ulcerative lesion, barrel-shaped cervix, contact bleeding, parametrial involvement, and pelvic wall fixation. Okay. Now, how does this carcinoma cervix spreads? It will spread by the direct route, then the lymphatic, and third is a hematogenous. So directly it can spread upwards, downwards, anteriorly and posteriorly. Okay, so when it goes from cervix upwards, uterus will get involved. When it goes down, vagina will get involved, laterally parametrium, anteriorly bladder, posteriorly rectum. Okay, so that is the direct spread, nearby tissues. Okay, so you have to write above, below, anterior, posterior. These are the things which you are going to write. Okay, the lymphatic spread immediately is a parametrial first, then comes the obturator, internal iliac, external iliac, common iliac, and para-aortic. So these are the lymph nodes which will get involved. Then hematogenous spread is the late feature. Common sites are the lung, liver, bone, etc. What are the investigations which we carry out? First is a clinical examination. Per speculum examination we will do. Bimanual examination, rectovaginal examination is required. Then come to the investigations. Okay, histopathology is the gold standard. Biopsy, you can take a punch biopsy, cone biopsy, or you can do the lip. This also we have discussed last time. Imaging, MRI is the best for the local staging. Okay, then CT for the nodal disease. If the nodes are involved, that will be seen better with the CT scan. Then for distant meds, PET CT is the best, and ultrasound in selected settings or in the initial evaluation, you can do ultrasound also. Okay, but however, MRI, CT, and PET has got their own role in the management of the CS cervix. Another important thing which you should remember is the FIGO staging. That is FIGO 2018 staging. Okay, so there are certain important changes which were introduced in FIGO 2018. There may be separate short note, and here you should be able to write not only the FIGO staging as such, but what are the features of this staging that you should know. Previously, we used to teach that the CS cervix staging is purely clinical. Okay, but here in 2018, imaging and pathological findings can now be used for the staging. Okay, previously staging was mainly clinical, but now imaging and pathological findings can now be used for the staging. Okay, that means your imaging features such as radiological features, maybe something on the MRI scan, pathological findings, histopathology, they can also be taken into account while staging. However, when you use, you have to note it down in a specific way. That also we will discuss. Okay, now stage 1B. Okay, stage 1 is restricted to the cervix. Okay, that is divided into 1A and 1B. Okay, so stage 1B is a macroscopic disease which is divided into three, that is B1, B2 and B3. Okay, tumor less than 2 centimeter is B1, less than 4 centimeter, that is 2 to 4 centimeter. So if it is a 2 centimeter, then it is B2. Okay, if it is less than 2 centimeter, it is B1. So if you are asked the management of a 2 centimeter tumor, then you will write about B2 management. If it is you are asked about the management of 4 centimeter tumor, you will write about the management of the B3. Okay, 1B3. Okay, so stage 1B is divided into 1B1, B2 and B3. Less than 2 centimeter is B1. 2 to 4 centimeter is B2. More than or equal to 4 centimeter is B3. Stage 3C is introduced for lymphatic node metastasis. Okay, so when we are talking about stage 3C, we are talking about the lymph node metastasis. Okay, this 3C is also divided into C1 and C2. If there are pelvic lymph nodes involved, we label this as a C1. If the para-aortic lymph nodes are involved, we label this as a C2. Okay, so 3C1 is a pelvic lymph node involvement, 3C2 is a para-aortic lymph node involvement. Okay, so this we are just discussing the overview of this FIGO 2018. That imaging and pathological findings are also given importance. 1B is divided into three phases. Then 3C is also divided into two, C1 and 3C1 and C2. And there are certain optional notations, because we have just mentioned in the beginning that radiological and pathological findings are also taken into account. So what are the optional notation that are, that is imaging based? If we are using the imaging for staging, then we will have to give notation such as 3C1R, that means pelvic lymph nodes are positive radiologically. Okay, if your MRI is suggestive or the CT scan is suggestive of lymph nodes positive, then you go for 3C1R. Okay, 3C1 we have seen pelvic lymph nodes involvement, but how you have diagnosed these pelvic lymph nodes? On radiology or on pathology? If it is radiological, you will mention 3C1R. If it is a pathology based staging, then you will mention 3C1P. Okay, so these are the features of this 2018 classification. This is not purely clinical as we used to say before. You can take into account the radiological and imaging features also. Now let us come to the staging as such. Okay, so we know that we have a total 4 stages: stage 1, 2, 3 and 4. Stage 1, where the carcinoma is restricted, strictly confined to the cervix. Okay, so carcinoma is strictly confined to the cervix in stage 1. Extension to the uterine corpus should be disregarded. Okay, so it is strictly confined to the cervix. Then 1 is also divided into 1A and 1B. 1A is a invasive carcinoma that can be diagnosed on microscopy. So it is a micro-invasive disease. 1A is a invasive carcinoma that can be diagnosed by microscopy with the minimum depth of invasion less than 5 millimeter. Okay, so here the depth of invasion is the less than 5 millimeter. So 1A is further divided into 1A1 and 1A2. Measured stromal invasion, if it is less than 3 millimeter in depth, then it is 1A1. 1A2 if the stromal invasion is more than or equal to 3 but less than 5 millimeter. So if it is a 3 or 4, it is 1A2. Okay, but if it is a 5, then it is 1B. I hope you are getting these minor things. So if you are talking in millimeters, because this is a micro-invasive carcinoma, 1A is diagnosed only on microscopy. Depth of invasion is less than 5 millimeter. This is also further divided into less than 3 millimeter. That means invasion 1 millimeter and 2 millimeter is 1A1, while invasion 3 millimeter and 4 millimeter is A2. But if it is a 5 millimeter, then it is 1B. So 1B is an invasive carcinoma where the deepest invasion is 5 millimeter or more, that is the greater than stage 1A, and lesion limited to the cervix uterus. Okay, so this 1B we have just seen in the beginning in the features. 1B is divided into B1, B2 and B3 depending upon the macroscopic size. So invasive carcinoma, more than 5 millimeter in depth of stromal invasion, but less than 2 centimeter in the greatest dimension. So less than 2 centimeter, I mean to say 1.9 centimeter. Okay, 1 centimeter and 9 millimeter is the here. But if it is a 2 centimeter, then it is a B2. Okay, so more than or equal to 2 centimeter, but less than 4 centimeter. That means 3.9 millimeter is a B2. Okay, but if it is a 3.9 centimeter is a B2, but if it is a 4 centimeter, then it is a 1B3. Okay, so invasive carcinoma more than 4 centimeter, more than or equal to 4 centimeter in the greatest dimension is B3. Okay, then stage 2. So in stage 1, what we have seen, the carcinoma is restricted to the cervix. Now in stage 2, the carcinoma goes beyond the uterus but has not extended onto the lower third of the vagina or to the pelvic wall. So here it has gone beyond the cervix as such, but not involving the lower third of the vagina or the pelvic wall. Okay, so here it is again divided into 2A and 2B. Okay, now modes of spread we have seen. One is a direct, second lymphatic, and third is a hematogenous. So here it is going to be a mainly the direct spread. Okay, so direct most common is going to be either towards vagina or laterally. Okay, so 2A is the involvement limited to the upper two-third of the vagina without parametrial involvement. Okay, so first downwards upper two-third of the vagina without parametrial involvement is the 2A, which is further divided into 2A1 and 2A2. If the size is less than 4 centimeter in the greatest dimension, we call it as a 2A1, and 2A2 if the invasive carcinoma is more than or equal to 4 centimeter in the greatest dimension. Okay, 2B if you have a parametrial involvement but not up to the pelvic wall. Okay, so in stage 2 there is a either vaginal involvement or the parametrial involvement which is not up to the lateral pelvic wall. Okay, so first we will talk about the vaginal involvement, but the limit is involvement of the only upper two-third of the vagina. Okay, then that is 2A. Okay, and that is also depending upon the size 2A1 and 2A2. If it is less than 4 centimeter, it is 2A1, and if it is more than or equal to 4 centimeter, it is 2A2. Okay, 2B is the parametrial involvement, but not up to the lateral pelvic wall. Okay, now let us come to the stage 3. Now what happens in the stage 3? The carcinoma will involve the, here in stage 3, you have to remember 4 or 5 things and you have to add and or in between. Okay, remember these, whatever I am saying now, please remember. Here in stage 3, lower one third of the vagina, lateral pelvic wall, okay, renal involvement, then pelvic or paraortic lymph nodes. These 5 things you remember, and in between each you just add and an or. Okay, so the carcinoma involving lower one third of the vagina and an or extending to the pelvic wall and an or causing the hydronephrosis or non-functioning of the kidney and or involving the pelvic and an or involving the paraortic group of lymph nodes. Okay, so basically here the carcinoma is involving the lower one third of the vagina. It is reaching to the lateral pelvic wall, or and an or it is reaching to the lateral pelvic wall, or and an or it is causing either hydronephrosis or non-functioning of the kidney, and an or pelvic or paraortic group of lymph nodes. Okay, so these are the things which are totally included in stage 3, and that is further divided into A, B, and C. So same thing what we have seen, these 4-5 things, they are divided into A, B, and C. Okay, remember stage 3C we have already discussed, that is the involvement of the lymph nodes. Okay, 3B will be concerned with the kidney. Okay, and 3B will be concerned with the kidney, and 3A will be concerned with the lower third of the vagina. Okay, with no extension to the pelvic wall. So if only the lower one third of the vagina is involved without involvement of the pelvic wall, then it is stage 3A. Okay, so here up to in stage 2, upper two-third of the vagina was involved. If it is a lower one third of the involvement without extension to the lateral pelvic wall, then it is 3A. If there is extension to the pelvic wall and or hydronephrosis or non-functioning kidney, unless there is some other cause for this hydronephrosis. If it is due to the carcinoma cervix, then it is stage 3B. Okay, so extension to the pelvic wall and hydronephrosis, renal involvement and the pelvic wall, that is in stage 3B. Then comes the stage 3C, that is we have seen pelvic group of lymph nodes or the paraortic group of lymph nodes, they are under stage 3C. That is also divided into C1 and C2. C1 is pelvic lymph node only and C2 is paraortic lymph nodes. Okay, this will also have R and P notations. If it is radiological, then we will write 3C1R. If it is a pathological diagnosis, then we will write 3C1P. Okay. Now coming to the last, that is the stage 4. Here there are distant mates. Okay. So the carcinoma has extended beyond the true pelvis or has involved the biopsy proven mucosa of the bladder or the rectum. Okay. And the bullous edema as such does not permit a case to be diagnosed or allotted to stage 4. So there should be mucosal involvement of the bladder and the rectum. Only the bullous edema is not sufficient. Okay. So stage 4, here the carcinoma has gone beyond the true pelvis and biopsy proven involvement of the mucosa of the bladder and rectum. Okay. So these are the criteria to label it is a stage 4. Stage 4 is also divided into stage 4A and 4B. In 4A, there is a spread to the adjacent organs, while in 4B, there is a spread to the distant organs. Okay. So there are certain very important things here you should. So even if you have understood everything, whatever I have explained, but there are a few important things mentioned here in small letters that are also equally important. Okay. So when in doubt, lower staging should be assigned. Okay. So when you are in doubt, what is the exact stage? If you are confused between the two stages which are next to each other, then lower staging should be assigned and not the higher staging. Because if you go for higher staging, there is going to be a aggressive treatment. Okay, you may over treat, and the over treatment, especially the oncological treatment, may have its own adverse side effects. Okay, so when in doubt, the lower staging should be assigned. Okay. Second, imaging and pathology can be used. That also we have seen, and wherever available, you can use it to supplement the clinical findings with respect to the tumor size and extent in all stages. The involvement of the vascular lymphatic spaces does not change the disease. So even if there is a vascular or lymphatic space involvement, the staging remains same. The lateral extent of the lesion is no longer considered. Okay, previously in microinvasive, there was a lateral extent also that was taken into account. So this lateral extent of the lesion is no longer considered. Okay, so adding notations of R and P, that is imaging and pathology, to indicate the findings that are used to allocate the case to stage 3C. Example, if imaging indicates pelvic lymph node mets, the stage allocation would be stage 3C1R. And if it is confirmed by pathological findings, it would be stage 3C1P. Okay, the type of imaging modality or pathology technique used should always be documented. Okay, so this is what is the feature. So even if you are asked about the staging, you should be able to describe the staging very clearly along with its explanation. Okay, here I will explain further that when in doubt, the lower staging should be assigned. What is the basis for it? We should not over treat, because the oncological treatment itself is a has got its own side effects. Say, for example, you are confused between stage 1B and stage 2A. Now, 1B is the cancer which is uh, restricted to the cervix, while 2A, where there is a spread to the upper vagina. Okay, now here you have got a clinical examination suggests that there may be extension to the upper vagina, but MRI is inconclusive. So you do not have any supporting evidence to, there is no visible also growth as such involving the vagina, but it is your suspicion is there, MRI is inconclusive, and there is no definite evidence of vaginal involvement, but you are suspicious about it, then you will assign stage 1B, that is the lower stage, and not 2A. Okay, because vaginal involvement is not confirmed. Okay, then if you are dealing with stage 3C1, that is the pelvic lymph nodes. Okay. MRI shows slightly enlarged lymph nodes, but we are not sure whether this is an inflammatory involvement or whether it is neoplastic involvement. PET-CT is negative. Then there is no pathological confirmation also. Then it is better to assign stage instead of stage 3C1. Then you do not assign stage 3C1 unless lymph node mets is confirmed by accepted imaging criteria or pathology. Okay, so if it is fully confirmed on MRI, then you will assign 3C1. But if it is just mild enlargement for which you are not sure, then we will not assign stage 3C1. Okay. So tumor size, tumor appears close to the 4 centimeter. Okay, but exact dimension is clinically you are just mentioning it is a close to the 4 centimeter. Exact measurement cannot be confirmed. Then 1B2 less than 4 centimeter rather than 1B3 which is 4 centimeter or more if there is uncertainty. So that is what is the significance of lower staging should be assigned. Okay. So from examination point of view, FIGO staging is based on documented evidence. If the available clinical, imaging, or pathological findings do not conclusively establish a higher stage, then go for the lower stage should assignment. Okay. So FIGO staging is based on a documented evidence if the available clinical, imaging, pathological. So clinical suspicion preferably should be supported or should be supported by imaging and pathological findings. Okay. And then you can assign, otherwise go for the lower stage. Okay, so the same thing about the staging. Stage 1 is confined to the cervix. 1A1 stromal invasion less than 3 millimeter. 1A2 invasion 3 millimeter or more but less than 5 millimeter, that is 3 and 4 is 1A2. Then 5 millimeter or more is but less than 2 centimeter. Okay, 1B1, 2 to 4 centimeter, 2 to less than 4 centimeter is B2, 4 centimeter and more is B3. Okay, 2A is divided into A1 and A2. Upper two-thirds of the vaginal involvement less than 4 centimeter is 2A1. 2A2 if the tumor size is more than or equal to 4 centimeter. 2B is parametrial involvement. 3A is lower one-third vagina involvement. 3B is pelvic wall pelvic wall involvement and or there is a hydronephrosis. 3C is a pelvic lymph node or para-aortic. C1 is a pelvic lymph node and 3C2 is a para-aortic lymph node. Stage 4 is a bladder and rectal mucosa, which you have confirmed on histopathology. Stage 4 or the biopsy proven. Okay. Stage 4B is a distance met. So I hope this staging is very much clear to you. Okay. Now from the Viva point of view and from concept point of view, certain things you should remember. Persistent high risk HPV is the necessary cause. HPV 16 is the commonest type which is involved. Transformation zone is the commonest site of origin. Postcoital bleeding is the commonest presenting symptom. Biopsy is the gold standard for diagnosis. MRI is preferred for local staging. FIGO staging incorporates imaging wherever available. 3C is the lymph node mets. Vaccination does not replace the screening, and prevention is the most effective strategy against the cervical cancer. Okay. So that finishes the first part of the carcinoma of cervix. Thank you.